Welcome to Ask Dr. Geier Live, wherever you're watching. Hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help athletes and active people like you feel, look, and perform your best, regardless of age, injuries, medical history, or hopefully anything else. Very excited to be here. My usual last Friday of the month live stream. It's been a while. Excited to be here. Hopefully you are too. A couple things to start if you've never done this that are important to know. One, as always, I am not giving you medical advice in answering these questions. I haven't seen you, examined you, looked at x-rays, MRIs. I'm not your doctor. You're not my patient. That's illegal to do if I don't have a license in that state, certainly not for people outside the country. I'm giving you information to help you understand maybe what your doctor or what your orthopedic surgeon told you, help you translate sometimes that confusing information, but I am not telling you what to do. This is not medical advice. Also, if you are watching on X, formerly Twitter, it seems very unreliable how comments there get over to my platform on Restream, which is how I send it out to the different social media sites. So if you are asking a question on X and I'm not answering it, maybe flip to the YouTube version of this show. If you're on YouTube and you want to ask a question, ask it in the chat, which if you're on a laptop or desktop is on the right side. Don't leave it in the comments. I can't see those. Those don't come over to Restream. At least 3 or 4 times pretty soon after the show, later Friday afternoon, I'll either see in the comments about the for this video, or I'll see it in email, people saying you didn't answer my question. I can't see the comments. I can only see what's left in the chat. So definitely leave those there. But if you have an orthopedic question, surgery question, rehab, recovery, you want to talk about some of the regenerative treatments, peptides, exosomes, stem cells, things like that, other health and wellness topics, this is your chance. This is really the only place, the only time that I answer medical questions. I don't do it in response to emails. I don't do it on social media, including YouTube and the comments to my videos. This is your opportunity. So this, definitely take the chance to do that. All right. Kaylee is coming to us, well, where'd it go? From South Africa. Very, very cool. And I'm going to start with hers because I saw it before we got started. Hi, Dr. Geier. I have a supraspinatus tendon tear, a superior shoulder subluxation. Nothing, including cortisone injections, pregabalin, and laser therapies helping. What can I do for the pain? All right, very good question. Again, not medical advice. Just let me give some thoughts on those topics. First of all, what she's talking about, I don't know if this can come apart. Looking at the shoulder, let me put this here. You got the humerus, you got the scapula, you got the clavicle. The shoulder, what we're thinking of typically is the ball and socket, the humeral head and the glenoid. The supraspinatus is one of the rotator cuff tendons, the tendons that come off the shoulder blade, 3 in the back, 1 in the front. They form tendons that run right under the tip of your shoulder blade. They attach to the ball of the ball and socket. What those rotator cuff tendons do is they stabilize the ball in the socket while your bigger muscles, deltoid, pectoral muscles, upper back muscles, reach up overhead, reach out away from your body, reach behind your back. So they fire to basically stabilize the shoulder. And they can be injured with traumatic forces. A lot of times, though, it is more overuse over time. 2 things, what she's talking about. One is a rotator cuff tear, that supraspinatus. We don't know full thickness, partial thickness, but the subluxation is essentially sort of a partial dislocation where the humeral head is sliding part way out of the socket, but then it pops back in. Again, in her case, I don't know if that's something that the doctor diagnosed or if that's just a sensation she's feeling. It matters because some subluxations are actually structural, meaning you've torn the labrum, the cartilage bumper along the socket, which you don't see here, or the capsule, the envelope that surrounds the shoulder, or both. That's typically something that occurs after trauma. Physical therapy I'm a big fan of for shoulder subluxations, because if you can strengthen the muscles around the shoulder, a lot of times that provides stability and does well. If it becomes a situation where even physical therapy does not relieve that instability, then you're typically talking about surgery, repair the labrum, and tighten the capsule. The rotator cuff really depends on the severity and some other patient concerns. Typically, full thickness tears and younger active patients more often than not need surgery to reattach that rotator cuff back down to the humeral head with stitches and anchors, and then a long period of therapy afterwards. If it's a partial thickness tear, very often you can potentially avoid surgery. So again, physical therapy I think can be very helpful. Maybe there would be a role for regenerative treatments for the rotator cuff part of this. I wouldn't expect things like peptides, things like exosomes or stem cells to have much bearing on instability issues. If there's a labral tear or capsular stretching out or tear, probably less likely there. As far as why the other stuff wouldn't work, I can't really speak for the last two, but the cortisone is problematic. One, that was never going to fix the problem, might at best relieve pain, but there are studies that show much higher failure rates of a rotator cuff repair surgery if you have a cortisone shot within 6 months of that surgery. So that's where, again, not to discourage you, Kaylee, but that's why, one of many reasons I'm not a fan of cortisone shots, but certainly for rotator cuff problems. So a lot to that. Again, not medical advice, but those are sort of my thoughts on all those different parts. Cool Water 83. Hi doc, I fractured and dislocated my ankle back in November. Is there anything I can do to avoid developing post-traumatic arthritis, or are you going to be doomed with arthritis at some point? Yeah, it's certainly hard to say, and it depends. This is where your doctor would be better able to tell you than I am, because I can't see what type of fracture and dislocation that is. Just generally, yes, that risk of post-traumatic arthritis is higher, but it depends on, did the fracture go into the ankle joint? It's when you get a fracture that goes into the joint, and now that surface is not lining up perfectly, when there's been disruption of that articular surface, and now it's not perfectly smooth. And yes, with ankle range of motion, with weight bearing, that starts to take a toll over time on the cartilage. That risk is going to be a lot higher. So it depends a lot on the type of fracture and how it had to be treated. Having said that, trying to prevent post-traumatic arthritis is tricky. I typically do not believe in backing off of activities, running, walking, other weight-bearing activities, plyometric exercise, that kind of thing. I don't think there's any evidence that necessarily lowers the risk of post-traumatic arthritis, but in my world, I think that's where things like penisin polysulfate may potentially be helpful. That's where, for the practitioners that do things like stem cells or PRP or exosomes, potentially that might be helpful. I would avoid cortisone, again, not medical advice, but that would be something I would worry would actually make the problem worse. But there would be things along those lines. But the biggest factor is, what type of fracture was it? Did it line up the joint well? And then, yes, there may be some preventative measures in the anti-aging and regenerative world that potentially could be helpful. All right. Jamie says, my left, hang on, I gotta read it over here. Left medius glute is super weak, causes my right hip, I assume quadratus lumborum, to activate. It's hard when people use these short terms, it makes it hard to read these abbreviations. Step ups, stands for, I assume Russian deadlifts. I can't do a single leg bridge on the left. I'm not exactly sure the question, to be quite honest. What I would say there is, get with a physical therapist that is very good with athletes, and somebody that really goes, not do they just put you on a bike and then put you on a table, you do your own exercises, and they do e-stem or ultrasound, and then that's therapy. Somebody that really figures out what the problem is, lays hands on you, puts you through all kinds of exercises to test where the issue is from, and then gives you, has you do exercises with him or her, but then also on your own to overcome those issues. That would be probably a better question for a physical therapist. In my experience, those that rehab athletes are much better at that than sort of the does a little bit of everything, physical therapists. All right. I don't know how to say that. Ruoliu? I apologize, I'm sure I got that wrong. What is an undersurface tear, the posterior horn of the medial meniscus? Can it be sewed instead of trimmed? So two different questions, and one doesn't necessarily have to do with the other. It can, but not necessarily. So the meniscus we talk about all the time. So the medial meniscus is the side closest to the midline of the body, and the meniscus is this C-shaped shock absorber of the meniscus. What that would mean from a radiological standpoint, or even if a surgeon went in there and scoped it, an undersurface tear means it doesn't extend to the superior surface, to the top. And in theory, yes, that becomes one that is repairable, but that's not necessarily the main factor. The main factor is more, is that tear out toward the periphery of the meniscus where there's an actual blood supply, and is it the type of tear, which again is usually vertical or longitudinal, that you can sew back together with stitches. And that I need to see the MRI. And to be fair, MRI is notoriously unreliable at showing a meniscus that's repairable versus one that's not repairable and has to be trimmed out. That typically is much better a decision made during the actual surgery. Some undersurface tears that don't extend completely to the surface are thought to actually even be able to heal on their own if they're near the blood supply. That's why that question is a little tricky. So the definition of an undersurface tear is straightforward. Is it repairable or not? There's a little bit more to it than that, and that's kind of what I'd look at. But again, MRI, notoriously unreliable. Numerous studies have shown in the hands of experienced musculoskeletal radiologists that MRI is not good at predicting a repairable meniscus tear versus one that has to be part of it trimmed out. All right. Let's see. Before I do that, Kaylee says it was diagnosed by X-ray. All right, very good. Mary, frequent on this show. I had my hip replaced in May, doing well, doing physical therapy now, and it really helps movement. So glad I had it done. Anything I should be particularly careful about doing? So I think the only thing I would say, and this would be a really good question for your hip replacement surgeon, but there are certain positions that potentially increase the risk of dislocating. And so there are certain ways that it's helpful to tie your shoes and put on shoes and things like that. You typically, I don't know how I'm going to be able to demonstrate it here, but there's certain ways that you could twist your hips that would put that potentially at risk. And so either your physical therapist or your orthopedic surgeon can do that. It's not super likely, but especially in people that have less muscle strength and muscle control, that's potentially a risk. All right, let's see here. Buttery Yak. I've been looking into BPC, reading about its benefits. I hear there can be side effects, anxiety, and anhedonia. What are your thoughts on this? I have not heard of that or seen that, side effects like that. Most studies out there reveal no real side effects. Most physicians that are certified in peptide therapy and are prescribing it have not really reported much other than local injection site discomfort, swelling, that type of thing, and even that is fairly rare. The oral, I have not heard any issues there. You've heard me say, not so much on this show, but in some of my videos, I don't know that there's much of a role for the oral BPC for orthopedic injuries. Doesn't seem to have much benefit that way, even though BPC is one of the few peptides that is well absorbed orally, that just doesn't seem to do that much as a pill that you take or a capsule that you take. But I have not heard those mental health issues. It's not to say it's not possible. I've said all over the place, we need more human data on peptides, especially randomized controlled double-blinded studies that are very expensive to do. And unless big pharma is going to pay for those studies, which introduces its own issues, or it's a government grant to study those studies are very hard and expensive to do. So I don't know when that's coming, if ever, but that would be helpful. But I have not heard of that. And from other peptide experts, physicians that do peptides, I have not seen that either. I don't know what to make if somebody describes that from these products, peptide products that they buy online. Who knows what that is? So I wouldn't put that in any kind of yes or no. I wouldn't know what to make of that. All right. I damaged the ACL, had the operation, cleaned the medial meniscus. The ACL is thin, has fewer fibers than normal. Can it increase in its diameter, and will you be able to return to football? That really is a question for your surgeon. That, in my experience, there's very few true partial thickness ACL tears that the knee is still stable, because most of the time it's the vast majority of fibers that are torn, and the ones that aren't are stretched out enough that it doesn't stabilize the knee. But in theory, if enough of the fibers are still there and they're still tight and they're stabilizing the knee, then it should really be something somebody could return to sports and exercise. It's not common, but I suppose it can happen. What could you do to increase the diameter? I don't know that the conventional world would really have much of anything. I do think physical therapy would be very, very important to strengthen the muscles around the knee and the thigh and the hip to better stabilize the lower leg. But having said that, maybe there'd be a role for some of the regenerative treatments, PRP, stem cells, exosomes, things like that. It's hard to know, but again, it's not super common. And so if it was a patient of mine, I'd want to see that MRI, see if there's a bone bruise pattern to show that, yes, maybe there's fiber still in place, but that knee is essentially unstable. A really good physical exam can also demonstrate instability of the knee, but I just haven't seen all that many true partial thickness ACL tears that the knee was still stable, because it's like a rope. It's not just a clean tear. The rope explodes. That's why you see all the frayed edges. And so yes, there may be a few strands of that rope still hanging together, but it's not essentially doing that much. Hopefully in your case, yours is one of the more rare ones. Do patients get a full recovery after meniscus surgery? They certainly can. It really just depends on the type of tear. If it's a repairable meniscus, there's no articular cartilage damage, absolutely that can be something that you can get complete recovery. If it's trimming part of the meniscus out, which is far, far, far more common, I think that long-term never have a problem again is a lot less likely, but it really depends. All right, how long does bone edema of the patella last? Everybody's different. It depends on how much that is, what the cause is. MRI studies of bone bruises in the knee have shown it's about 6 weeks before the MRI doesn't show the bone bruise on the next one. So that's what I'll say here, but there's a lot of different factors that might affect that, either shorter or longer. How long do symptoms last would be a very different story. Symptoms could be much longer. The MRI is just showing the edema in the bone. Pain from it really depends on not just the bone contacting bone, which is what causes the bone bruise, but then what the underlying issues that led to that are, where the ligament tear or anything else. And so that probably could be longer than 6 weeks, but that's really hard to know without knowing more of the specifics. Bunch of the same people. What are your feelings on taking antibiotics before dental prophylaxis? I am sort of out of that world for how long, but my understanding is, last I was in that world, I think it was still taking them before any dental procedure and for the rest of your life. There is very little downside to not doing it, but the risk if you got a hip joint infection is so catastrophic that it's probably worth doing just an antibiotic dose before the procedure. That I have not heard that recommendation has been changed. And Mary says after a joint replacement. Yeah, that's what I was talking about. But I will tell you, one, I never did hip or knee replacements. I was on the sports medicine side, typically younger, more active patients before they develop full-blown arthritis. But I have not heard the joint replacement worlds, the Hip and Knee Society, has changed their recommendations, and that would potentially be why, because the risk of a septic hip would be so bad in terms of, the metal and plastic would have to come out, do antibiotic spacers, and potentially PICC lines for long-term IV antibiotics, and then putting a new hip and knee back in, potentially, that you would not want to take a risk of that happening. Let's see. How should I decide whether I need meniscus surgery? It really depends on symptoms. It depends on age. It depends on a lot of different factors. If you've watched recent videos of mine, numerous studies over the last few years have come out showing that in older patients, especially with some arthritis changes, that surgery is not only not helpful, but it actually leads to the development of arthritis and the need for a knee replacement much faster. And so the trend is getting away from recommending the surgery to trim out part of a meniscus tear for that type of tear. In a young active patient with a repairable meniscus, like a bucket handle meniscus, I feel that most sports medicine orthopedic surgeons still believe that that's useful. We'll see if those recommendations change in the coming years, but that typically, the more active somebody is, the more the younger they are, the not having arthritis changes and potentially mechanical symptoms, locking, catching, those would sort of be the indications to do it. All right, this is going to be our last question of the day. These have all been great. Right knee surgery last year, July 12th. So we're getting real close to a year. Meniscus was detached. What could cause back of the knee pain? In both knees. I'm not sure why you'd have pain in the other side when it was just one surgery, but there may be more to it. It could be limp and more stress on the non-surgical knee due to the pressure. I don't know, without examining somebody. Typically, meniscus tears are in the back of the knee. So you're looking at it from overhead. They're in what we call the posterior horn of the meniscus. So that could be where some of the work was done. It depends a little bit, as we were talking about at the beginning of this show, was part of it trimmed out versus sewn together with stitches. Those would lead to two different potential sources of the pain. Was there any associated articular cartilage damage, i.e. early arthritis? Did you not get full motion? I'm not full motion. That would do it too, but that's pretty rare after a meniscus surgery. But not get full strength back, and now more pressure is going to the bone and cartilage. There's a lot of different factors there, but those would be things that I looked for. And on that note, Mary says, thank you for all your information. Have a great weekend. Yes, thank you so much, Mary. Thank you to all of you. These were great questions. Very, very appreciate you coming here. Usually it's the last Friday of every month. That varies depending on some holiday and that kind of thing. But we'll be here July 26th. So the last Friday of July. Very excited to be back here. I very much appreciate you being here. Have a very safe, have a very happy weekend, and I will see you all real soon. Take care.